It's my pleasure to introduce Professor Derek Tracey, who's the Chief Medical Officer and the Executive Director for Psychological Therapies at the South London and Maudsley NHS Foundation Trust. Derek is an adjunct professor at the Institute of Psychiatry, Psychology and Neuroscience at King's College London and an honorary professor at Brunel Medical School. His research focuses on policy and cultural aspects of creating better integrated care system. He's published over 150 papers, is a member of the Advisory Council on the Misuse of Drugs with a special interest in the health risks that arise from new novel psychoactive substances or legal highs. In between all of this, Derek finds time to be the deputy editor at the British Journal of Psychiatry. He writes its kaleidoscopes and highlights columns. He's the editor of the leading UK textbook on the Coroner's Court and the forthcoming Royal College of Psychiatry textbook, Research Methods in Mental Health. Finally, at the Royal College of Psychiatrists, Derek is an executive member of the Occupational Psychiatry Special Interest Group. In 2020, he was co-opted as one of the medical leads to design and run the mental health team at the London Nightingale Pandemic Hospital, work which attracted an award from the 2021 Royal College of Psychiatrists Team of the Year. His other notable awards include a 2024 RC Psych President's Medal, the 2019 College of Psychiatrists Communicator of the Year Award and the 2015 King's College London Teaching Excellence Award. So it is my pleasure to introduce and hand over to Professor Tracey.
Thank you for the invitation along. I'm going to talk about part of my work, as Dan mentioned. I'm the CMO at SLAM. My primary work is medical leadership. I have a real interest in the cultural factors that impact our staff. We've 7,500 staff at SLAM. And I've done some research and some practical work into staff well-being. I'm not going to teach you how to suck eggs. This is really complex, this whole area, but I'll talk about some work we have done previously, including taking the London Nightingale as a particular example. It's an atypical example, I take that, but the evidence base that we've used with colleagues, a lot of it precedes and was exemplified by that. So I will try share my slides. I think I've got about 20 minutes and then about 5 or 10 minutes for questions.
That's right. Yeah, if you can keep it to 20 minutes, Derek, I'll raise my hand when you're at the 20-minute mark.
Okay. And I'm assuming you can now see those slides?
All good.
Good. Okay, great. So I'll talk a little bit about why I'm interested in this area, particularly around integrated care and culture within workforce. I'm mindful this is quite a mixed audience of different backgrounds. I'll go through the London Nightingale as a very atypical exemplar, and then some thoughts and lessons maybe to open up for a conversation about what is it you might want to do where you are in terms of maybe practical things or in terms of research. So a lot of my work on back in medical leadership over the last 5, 6, 7 years has been around integrated care, which would be, I suspect, a phrase at least, which you'll be familiar. And some background to this, the reality is the UK's population is changing and the pressures facing healthcare are significantly changing. The population is rising, so a lot of Western countries or high income countries, the population has peaked, but we're still growing in the UK. But moreover, the population is aging. And if you look at that demographic classic triangle, it's really shaping into an older population in the UK, which has lots of impacts on us. One, it impacts the workforce, so the people coming behind, there are fewer of them. People who are older are going to have more complex healthcare problems, more comorbidities. It's one of the great successes, of course, of healthcare systems that we have this aging population, people who previously died. A challenge for us all, I'm sure you're very familiar, is that finances are not keeping up with this. So in my organization this financial year, we had a 5% cut. And that's £36 million we just did not get this year that we had last year. It was just taken out of our budget. And then our workforce, I don't know how it is where you are. It tends to vary from post to post and place to place, but 5 to 10 to 12 to 15% vacancies are not unusual. So with this growing population, it's an aging and more complex population. The workforce and the finances are not keeping up with it. And so practically, we can't just keep doing what we were doing before. And one of the proposed changes to help with this is to move to more integrated care systems. Now, in a sense, this is just a practical reality. If we've got a limited workforce, we've got limited finance, we've got those challenges, can we do things slightly differently? But there's a philosophical and evidence base for this in any case. So there's an evidence behind, I'm not going to go into it in this particular talk, but if we think about social determinants of health, strengths-based approaches to working with people, it's a better way to do business. So this is kind of an interesting thing for me in the background, this move to integrated care. The problem, this is a paper we've got, these are just the proofs, as you can see. It should drop any time in the next few days. We've done some qualitative work looking at the impact of that on staff. So in a sense, this is one way to deal with a reality of a problem that we've got. But the short of this, which won't surprise you, is culture eats strategy for breakfast. And one of the real challenges we have, so we did some qualitative work looking at frontline NHS staff, looking at NHS executives, and then looking at integrated care boards, the different layers of NHS leadership and clinicians. And people get this. People say, sure, I understand why we're doing it. A lot of people are philosophically in favor of it. It's hard to be against the integrated care. No one's in favor of disintegrated care, but it's all the granularity. But what does it mean? What does it mean for me as a professional? Is it going to change what I do? Are you replacing my job? And people know need is going up. It's getting more complex. Are we just being turned into this gray goo? We just have to do everything all the time. And the cultural bit has been really underlooked in terms of, one, how you carry your staff. We've got a paper, it's not published yet, it's called Lanyards and Car Parking. And the principle of that is, we came in with some of our integrated care work in my leadership. We were talking about all this high level stuff about populations. And people said, where am I going to park my bloody car? And we hadn't given them enough information on practical elements. So there's something about that. And then actually, a thing I'm really interested in, cultural gains through integrated care. I have a different piece I can forward on to. One of the real emerging benefits from this is your education, your training doesn't just give you a knowledge set, it gives you a way of seeing the world. And there's some real cultural gains from having different types of professionals work more closely. Problematically, large-scale systems tend not to think about the cultural bit, either about the things that cause folk problems or about the things that might give us and might help us in times to come. So a lot of my interest is through this work that I have to do in leading more integrated care systems, and then trying to do this properly with my staff and trying to work together and help them. So what I suppose I'm starting off with this point to say is, my interest is because this is the reality in which we're working, and we are in difficult times. When I meet our resident doctors, if I'm feeling in a bad mood, which is pretty common these days, I sometimes tell them that they are currently working in what they will call the good old days in 2035, because if they think it's busy now, 10 years from now, the population will be larger, it'll be more complicated, and we probably won't have as many staff. So there's something really challenging about this, and we can't just go blindly into it. So how are we going to look after ourselves? So I'm going to talk a bit about an unusual part of my career that only lasted a few months but had a significant impact on me. It was the London Nightingale Pandemic Hospital. And I think many of you will have heard about it or seen it on TV. It was a heroic failure, and I'll talk about the failure part at the end. It was set up for a hospital. This was in 2020 when the first big wave was coming across Europe. And you might remember in Italy at the time, there were huge problems. We're seeing hospitals being completely overwhelmed with folk with COVID. And what happened in the UK was the Excel Centre in East London, if you happen to know it, was requisitioned by government to be set up as a specific pandemic hospital, a 4,000 bedded ITU to take this anticipated wave. And following the evidence, it was really clear that this was going to be brutal to work in. And I was co-opted with some folk to set up, as part of the Nightingale, the mental health support for the staff who would work in it. It was anticipated we would have 16,000 staff working in this hospital, and we wanted to support them. We anticipated huge mental health problems. And because of my interest that Dan mentioned in occupational psychiatry and mental health, and my work at the Royal College, we were asked to set up a bespoke team. So we're co-opted into it. And that's the beginnings of our team on the left. So it's about 5 years ago. I had no grey hair. CMO life has been harmful to me. Our team, you can see Mark Tarn on the right, Mark Eldridge on the left. That's Professor Neil Greenberg in the middle. He's not behind me. Neil is only about 1 foot tall. I'm lifting him up like a little hand puppet there. So that was our core team to begin with. And on the right, you can see the London Nightingale, We went in at what was called day minus 21. So that's D minus 21 days before it opens, as you would expect. And the lessons are really clear. You can see the Army Engineering Corps laying this out. And it was shocking when I went in that day. And I'm going to come on to that in a minute. I think it was, I don't know if I had different stresses throughout my career. It was the one moment I really felt overwhelmed. We'd agreed to go and do this. And I walked into it. And if you've been in the Excel is a kilometer long. And so as a thought experiment, if you're walking home from work later on, if you time yourself, it takes an average person 8 to 9 minutes to walk a kilometer. Time 8 minutes, and for the entire 8 minutes, if you imagine on the left and on the right of you are just ward after ward after ward, going 10 beds deep on either side, and they're just ITU beds. Walk that for 8 minutes. So 4,000, when we went in, the Army had laid out the tape on the ground. And it was completely overwhelming to think what we're trying to do. And the mission was clear. By day 1, there had to be 6 beds in it. By day 7, there had to be 600 beds. By day 21, there'd be 2,000 beds. And by day 28, it'd be up 4,000 beds running. They had a mortuary inside it that would hold 600 bodies at a given time. We went in and there was an articulated lorry turning within that space, because the expectation at that point was 50% mortality, because this was only going to take ITU patients. It was only going to take people with a low likelihood of surviving. So we were expecting 50% death rates, and it had to be able to hold 600 bodies in the mortuary. The mortuary at the side of it had a taxi rank area that ambulances could come and take bodies away. I mean, it was really astonishing to see it. And it was an unusual time. The only time in my career, going back to the money question, we had pretty much limitless resources. You could have anything you want. You'd say, I want 5 computers, and they would just bring them in immediately. So it was a weird time. You were able to set up anything you want. So we were given that task. Day minus 21. By day 1, you need a 24/7 team. It's going to have to be ready by day plus 28 to look after 16,000 people. And you have to do an evidence-based piece of work. So I was taken out. I still had to do my clinical director part as it was at the time, but I was co-opted out and I was given 3 days a week and then evenings and weekends to get this thing set up with Neil and Mark and others. And so a couple of key concepts, and this is where, of course, that's a really atypical example. It's atypical in my career and it's atypical for all of us, but it opens up some issues that are not atypical. And when I talk through the model for the Nightingale, I suppose what I pitched to you is, how does this fit into where you work? And the first is the concept of moral injury. I think you'll be familiar with it. It was a newish term, I think, 5 years ago, although it wasn't invented at that point. And the idea that being put into unexpected, psychologically challenging environments tests, the moral injury comes from it's a military phrase to begin with. It tests your moral integrity. So the classic example that's often given is, if you're in the military, you're under fire, your life's in danger, but you call in an airstrike and you know it's going to hit a village and kill loads of innocent people. How does one support that? And the moral injury here was going into an environment that one had not trained for. And very few of us, I mean, maybe if you're a trauma surgeon, but 50% death rate and 4,000 patients, it was going to be a factory of death. But the second idea is post-traumatic growth. So we think about PTSD and disorders from stress, but of course, most folk get through trauma and they develop from it. Trauma is never wished for in life, but we grow. So the old phrase, what doesn't kill you makes you stronger, has some evidence behind it. And here's the evidence-based model. Now, I've only got a short period of time with you. I'll give you the links to the papers here, but this is an evidence-based approach. And from an occupational psychiatry point of view, which is my background, you can approach this from 3 different tiers, what's called primary, secondary, and tertiary prevention. And I appreciate this will be familiar to some of you. I saw someone in the chat with an occupational psychology background. But the principle is primary prevention. How does one stop problems occurring in the workplace? Secondary prevention. How do you rapidly identify problems as they start to come out? And tertiary prevention. How does one quickly treat any illness or disorder or problems that do come? So 3 different layers to tackle it. Primary prevention, what we used to do was we had to go in to do really frank, honest inductions with people. So we had at the start with the Nightingale, it was an entirely voluntary workforce, and I had huge admiration for people who stepped forward. They knew what they were going into, and this, if you think back to COVID, it went through strange phases. This was an era, you saw in that picture, we actually did not have masks at that point. They were being saved for for other parts of the system. We didn't have vaccines. People were going to go in and work there, as some of you will have done, and then gone home to your family and friends, and you might infect or you might kill your family and friends from it. And you're certainly going into a place with really vulnerable, unwell people. We had to talk through them with the anticipated mortality rate, the fact that there was liability that they might get stuck in the Nightingale where we wouldn't be able to release them for any number of reasons. We had, government had requisitioned all the hotels around the Excel to house the 16,000 people. So people were told, you might get stuck here and we may not be able to let you out. But there was something about the honesty and frankness of discussions, having accurate, up-to-date information. I'm fascinated. I've not done it with your organizations, but you go into, certainly in the NHS, you go into trust websites and it's just way out of date. I look at a service description, I think that person's dead or that person's left. So it was something about being very honest with people, being frank, having really good information all over the place for people, and have really good training. And to note there that the evidence says that psychometric personality pre-screening does not work, by the way. So being frank with people is helpful. Being honest with people, telling them about the challenges they're going to face is useful. Role-specific induction is useful, but testing for some form of heroism doesn't work. You get some people who think they're quite fragile and they do great, and you get some people who think they're Superman and they crumble. It's not a good way to check. Secondary prevention, some things we did. That's not a photo from the Nightingale. I couldn't find one for the particular thing I wanted, but buddying up. So the other thing, if you remember the full PPE kit that people were going in, so you could just see eyes, and these were new people in new teams. That was the year, if you remember, where medical students and nursing students were rushed through the last few months of graduation straight into training. People in teams that didn't know who the other people were insofar as they'd never met them before, and then you couldn't see them. You got eyes. It was a really claustrophobic, challenging environment. So we would do the name tags and we would pair people, and you had your buddy that was the person that you were meant to find during your shift and check up on each other. I'll put down one professional group did not engage. Doctors don't do this so well. I don't know what it is. I'm a doctor. I don't know what it is about medics. They'll do it, but you have to really give them a bit of a kicking over it. Kicking's not a good way to help people, by the way. That's not a good occupational psychiatry approach. That's just a turn of phrase. And then the other thing we were doing with them, which again you might want to think about in workforces, were post-shift debriefs. So what we would call psychologically savvy conversations, and watching for presentees and watching pediatricians, all different groups of folk there, and that might not be as much of their training. We were taking in dentists, surgeons. There were people who were clinically trained, but maybe the psychologically savvy was less of their world. And part of our work in leadership was we worked with the leadership team to work with their own staff about having those conversations. How does one engage and check in? The other thing we did was peer support and welfare walkers. This is part of Neil Greenberg's work from the Army trauma risk management model. And basically this is peer-to-peer support. So you can see me there in the corridor of the middle part of the Nightingale. They had all these, it was funny, all the shops in the middle were open with food and supplies, but no staff. You just went in and took food. It was like one of those childhood dreams. You could go in and take chocolate bars and stuff. So that's part of the central part. And those people behind me, they are actually aircrew from EasyJet, and they were our welfare walkers. So they weren't working at the time. EasyJet gave us loads of their staff. They volunteered. They were fantastic. And people, that the principle here about the peer support is people felt more able to approach them than middle-aged guy in a suit at the front, which is me. And they had those t-shirts. They're readily identifiable, and as part of the induction we told people that's what they look like. And by the way, hats off to aircrew. If you want a group of people who can engage and chat to people, they are the best. They were fantastic. They saw you sitting down, they'd pop over, they'd say hello. They felt you weren't in the mood for it, they'd let you be. They were great for walking the floor. And tertiary prevention, there's Andy and Mark. So that's when you actually had a problem. So someone's saying, I'm stressed, I'm feeling blue, I'm feeling low, I'm not coping. We worked on what's called the PIES model. And again, I'll give you links to the papers that have some of the data behind this. So the PIES, you can see it there: proximity, We were on site in the middle of the Nightingale. You didn't have to leave your work to get to us. Now, there's an issue of resources here. I fully understand that. But this is, again, if you're following the best evidence for it, immediacy, there was no booking process. You walked in and we would see you. Expectancy goes to the point that we would expect to get you back to work. I mean, we might change your roles, we might change your hours. We didn't expect to sign you off. We would take a model of expecting to see how we could support you. And then simplicity, again, keeping it nice and simple, getting folk into work, taking them off when you had to. So fairly straightforward model. And then a really interesting part of the Nightingale was it was not needed. Now, this is really complex, and I have personal complex feelings about this because I worked there. And I remember at the time, you might remember, there's a lot of criticism in the papers about a white elephant and so forth. I'm not taking political sides. I guess had it been needed and not created, I think there would have been a very different problem. So I'm glad it wasn't needed and it was stood down. But actually, part of the recovery for staff, the staff who volunteered there took it really badly. They were very upset. People walked in, and I have such admiration for the people who went in. They went in expecting it to be the worst that it could be, and they went in anyway. And then they read a lot of stuff in the paper saying, you know, the white elephant, and they felt it personally that they'd done something bad. It was really interesting, the psychology of the staff. That's actually the O2 in London. Again, what a weird time. We said we needed somewhere to talk to staff, and they said, well, do you want the O2? And we said, fine. So you can see me in the middle. The only time in my career I'll be on stage at the O2. And we had those cufflinks as something of that we did for the leadership team, for us, about recognizing what we had done. I'm not looking for heroism with it, but there was something for ourselves too. There's something about recognizing the challenge that folk go through. I think Dan's got the slides. I'm happy. These are some of the papers we've done from this that detail more of the evidence base that I've talked through really, really quickly. So on to next steps and lessons, and then I'll turn off my slides and open up for conversations. So going back to the beginning, we're in a really, really complex environment now in clinical life, in academia life. It's really, really difficult. It's complicated. It's multifactorial. Problems are growing. I'm telling you your own business here, but I'm pretty sure you are working in a tough environment. And although the Nightingale is a very atypical exemplar, there is an evidence base for supporting your staff, and it can be applied locally. You can target professional groups. So the Nightingale is very unusual, but you can see a piece we've done on the left there with cardiologists at King's. And I don't know if any of you are cardiologists, but cardiologists have a bit of a reputation for a very machismo, if patients die, get on with it type of attitude, and they find it difficult to talk to each other. It might strike you as unusual if you're not a cardiologist, but certainly something within it. And then maybe something closer to home for you on the bottom right. This is a paper my colleague and friend Radha Katari is leading on. Clearly, it's just being written up at the moment, but looking at moral injury in academics, particularly those involved in clinical trials. I don't know if this impacts any of you or something you feel, where sometimes, especially if there's life preventing or life-saving treatments and one is enrolling in trials, you can imagine the complex psychology of people volunteering for maybe their last hope and then being randomized and getting placebo. There's a really unspoken challenge about some of the impact on researchers in that field. You can look at particular types of problems. We did a piece there on looking at regulatory standards. I'm currently going through a CQC inspection. I could do it like a hole in the head. It's not helping my general mood or my week, but regulators have to be there. But you'd be familiar about there was a death by suicide of a school principal during an Ofsted inspection. So there's a complexity about regulation, with a piece there on the right about some of the societal and work elements to employment. And then a caveat too, there's lots of nonsense out there too. So there's lots of apps. Some of them may be fine. You got to be careful about adopting stuff at scale. I mean, that's obviously nonsense there. Amethyst, it's not about peace, it's about hope. So I wouldn't buy that particular tree. And you can also be inauthentic and counterproductive. I don't know if you remember this during the pandemic. I can't remember which trust. Oh, there it is. Worcestershire Acute Hospitals. To say thank you to staff, they posted them a tea bag. Now, it may not shock you to hear that most folk who got that wanted to hit the chief exec over the head with the tea bag once it was covered in boiling water. That's a really stupid thing to do. So how does one do this in a non-counterproductive way? And then there's something about not putting, I'm a bit of an aversion to the word resilience. It puts problems in people rather than systems. If I get 2 or 3 staff coming to me and they're from the same ward, I don't wonder why they're all getting depressed. I wonder what's wrong in that ward and the culture and the systems and the leadership. So there's something about having a systemic viewpoint too. Some ongoing work we're doing, as some of you might know, this SLAM is linked with the Institute of Psychiatry. They were kind of sister organizations. And my colleague, Professor Jamie Delgadillo, is doing some work at the moment with us in SLAM with our staff. This is ongoing research. It's really interesting. His first trial, this is out and published now. Jamie was comparing internet facilitated CBT. So because of the way it runs on an internet basis, it needs staff, but not very many staff. You can do it at scale. It's fairly quick succession, so we can put loads of people through it. And he compared it to job crafting. So the CBT approach, you can see the principles there, is trying to work through the kind of burnout model with folk. And job crafting, which is trying to change the job to better work with you. Now, interestingly for me, I don't know what your thoughts are. My prediction would have been job crafting was superior. CBT in his model seems to be, well, it is statistically superior to job crafting. And we're now doing some follow-on work with our inpatient staff, taking a guided CBT model, trying to take out particular mediators of that and how we can actively intervene. So it's both an intervention and it's a trial at the moment. Oh, and I was going to finish there. So Dan mentioned forthcoming textbook, if any of you want that. Also edited by Professor Joyce too, so I'll get that plug in. And if you are interested, there's my recent editorial on the future of mental health care. Right for time, I just, and to summarize, so I appreciate the some of that. There's an atypicality to what we did there in the Nightingale in particular. But what I'd say to you is our work environments are really, really tough. I don't think we can or should be passive with this. There's stuff we can do, and culture beats strategy. So what do you do, I suppose, my question. I don't have answers for you on all of that, but maybe to open up to thoughts or reflections.
Derek, thank you so very much for coming along, taking time out of your day to talk about your work. It was genuinely fascinating to hear it. We have time for maybe 2 questions. If you have a question, would you mind raising your hand? Mandy.
Hi, I can't leave a complete silence, so I will ask a question. I think it's really interesting that the links potentially with the patient safety work and the Patient Safety Commission, and how their work on culture is, and the work that Jane O'Hara is doing at WISE as well, or WISH is it, in Cambridge, around how culture impacts on the safety as well as the outcomes for staff. And I think it's really, I know we haven't got all the answers yet, have we? But there's quite a lot of improvement work and sort of service level improvement work that's testing some ideas and some things around that. And Amy Edmondson's work as well around psychological safety, and how in some respects that kind of conflicts with patient safety is also really interesting. So thank you, that was really helpful.
Thanks. And we think about things like mid-staffs. It's always culture, isn't it? Always. And it's one of those really intangible things. We can taste it, but we've difficulty describing it or weighing it. So how does one quantify it? But it's always a danger. We have tick box. Here's the thing to do on the ward or the team, but we know the culture that's supportive. I think it's hard because it's complex and multifaceted, and I wonder if it's because of that we know it, but we steer away from it. And instead, we come out with a 5-point things you must do today, rather than how do we have a high functioning team, and how do we learn from good teams. We tend to go in with teams that are terrible and say, let's make that less awful. We don't tend to go into high functioning teams and say, I wonder what they're doing well. But I think in terms of patient safety, staff well-being, and my biggest learning with the integrated care was the gains for staff in working with different professional groups, how they began to, if I told them to do it, they wouldn't have done this, but they began to model each other about the different ways of seeing. It was really, really fantastic. And I think in integrated care, my anxiety for the NHS is it's not paying adequate attention to the good and the bad parts.
Thank you, Mandy. Thanks for the question.